I'm going to give you then for the last few minutes of this presentation, of this meeting, the hot topic of atrial fibrillation in the context of a cryptogenic stroke and transcatheter PFO closure. The objectives of my lecture will be to talk about the importance of AFib as a risk factor for cryptogenic stroke. Number two, we're going to go about what's the ideal methodology for AFib detection in patients that have cryptogenic strokes. We're going to talk about the incidence, time course, and clinical consequences of AFib in patients that undergo transcatheter PFO closure. And finally, I'm going to propose some treatment recommendations of what happens when a patient that receives a device develops AFib. So let's talk about the importance of AFib as a risk factor for cryptogenic strokes. And I'm going to refer all of you to this great summary of the topic of cryptogenic stroke that was published about 3 years ago in the New England Journal of Medicine. This is a mandatory article that we all need to do and read and know very well because it deals with the patient population that we're evaluating for closure, and it has up-to-date recommendations from both the cardiology and the neuro perspective. So if you read this, the definition of cryptogenic stroke in this paper, they'll tell you it's the stroke that has no cause after initial standard evaluation. And it turns out it could be almost 40% of all strokes. But the other interesting fact that has developed over the years is that atrial fibrillation is now increasingly recognized as a cause of the cryptogenic strokes in many of these patients. But I'm going to go back to the year 2000, in which the first guidelines were developed to the workup of a cryptogenic stroke. Megan went through this. But in the year 2000, when you presented with a stroke, in terms of cardiac rhythm monitoring, all that it was required to label you as cryptogenic was either do an EKG or have inpatient cardiac telemetry when the patient was admitted for a day or two after a stroke. And our Holter monitor that back then was only 24 hours. So if you didn't have AFib in any of these tests, you were considered to be cryptogenic and therefore candidate for a closure device. So this was the standard of care in the year 2000, and this was the standard of care that the PFO closure trials adopted in the year 2000. For example, in the year 2002, the RESPECT trial was initiated evaluating the implantable device versus medical therapy for the prevention of stroke. And if you look at the workup that was done to detect AFib in that study, you're going to look at baseline. All that was required was either an EKG or a Holter monitor. And also, if you look at the follow-up of the patients, you'd only need an EKG at discharge and then a 1-month follow-up. It's hard to believe that many of these patients came for follow-up appointments 3, 6 months, 1, 2, and 3 years out, and they were not even required to get an EKG at their follow-up visits. Even more interesting is that when a patient had a stroke in the RESPECT clinical trial, this was the evaluation that was performed in these patients after a stroke. About only 7% of these patients actually underwent a Holter monitor to detect whether they had atrial fibrillation as the cause of the stroke, which is kind of very interesting. Now we go to the reduced clinical trial. It started 6 years later for the evaluation of the Helix and Cardioform device. And in this study, as well as the prior one, for the baseline screening, all that was required was an EKG, not even a Holter monitor, as an inclusion to rule out atrial fibrillation as the cause of a stroke in a patient. So along the way, they came in a year around 2014, a study that is a landmark in the field, that it was the Crystal AF study. The Crystal AF was a study that randomized implantable loop recorders versus standard EKG Holter for the detection of atrial fibrillation in patients with cryptogenic stroke. And as you can see here, if you look at the detection of AFib at 6 months, if you have an implantable recorder in the red curve, you had about a 10% chance of having AFib detected at 6 months compared to only about 1% if you only go EKG Holter. And at 12 months, that percentage went up to 15%. So since this study came out, definitely became evident that an EKG and a Holter was not sufficient to detect AFib in patients with cryptogenic stroke. But so this is like all AFib detections. So are all AFib detections the same? Does it matter whether you have a 5-minute AFib versus like a 3-hour AFib protocol? So We're going to the study here that evaluated 10,000 patients that underwent implantable loop recorders, and they followed these patients and detected what are this, in this population, which patients had a stroke, and then went back and interpreted the loop recorder. So the first interesting thing about this is that if you look at AFib, about 60% of them will be less than 5 minutes of AFib. So half of the patients will have very short episodes of AFib that are unlikely to be clinically significant. But then the question was, in this population of patients that had a stroke, which was the duration of AFib that was the cutoff in becoming clinically important? So they did a Cox reduction analysis and looked at duration of AFib, and it turns out that if you have AFib for more than 1 hour, you had a hazard ratio of having AFib that was 2.09 times higher than if you had AFib for less than an hour. So based on this data, it turns out that we think nowadays that an AFib duration needs to be at least an hour before you can determine that this is a risk factor for a stroke. So now that we know that AFib can be undetected unless you do a prolonged monitor, what is the ideal methodology for AFib detection in cryptogenic stroke? So first we have to understand that there are factors that increase the risk for AFib, so we can actually tailor the strategy of detection. So we know that if you have an age greater than 40, if you had a CHAT score that is greater than 2 or 3, or if you have an MRI consistent with embolic stroke that includes multiple vascular territories, or if you have what is called now left atrial cardiopathy, which is either LA dilation or reduced MTN on echo, or morphology of the left atrial appendage has been implicated, or that, any of these factors that you have in a patient actually warrants that you do prolonged monitor, that just an EKG and a Holter is not enough. So based on this risk stratification, we are going to talk about what are currently the strategies for detection of AFib. Robert already mentioned this very critical paper that it summarizes the expert opinion of how to work up patients with PFO. So if we go into look into specifically what it said about PFO and AFib, they're saying in this paper that a period of extended cardio monitoring should be performing for approximately 4 weeks in patients above the age of 40 with a presumed cryptogenic stroke before you can decide that they're candidates for PFO closure. They also say that it's a shorter period of time, even just 2 weeks, with nowadays is a Zio pad. Then if you're under the age of 40, it's okay to do only 2 weeks, unless you have risk factors for AFib under the age of 40, such as hypertension, valvular heart disease, and whatnot. So based on these recommendations, now is standard of care that you have to do prolonged monitor that is either 2 weeks or 4 weeks, depending on the age and the risk factors. So this is a recommendation of the SCAI American perspective on it. But the Europeans actually are going a step beyond that, and they actually came together already last year with their position paper on the management of PFO closure. And if you look at this in this study or this consensus, they basically recommend that if you have a cryptogenic stroke and you presume paradoxical embolism, you're obliged to rule AFib. And if the patient is above the age of 65, it's mandatory to put an implantable recorder. How long do you monitor the patient? I have to say that at least 3 months is what most people will argue is adequate to rule out AFib. Some people are using 6 months, and in the older population. But if you're under the age, if you're between 55 and 64, and you have risk factors for AFib, which you already had mentioned, then they also propose that you undergo an implantable loop recorder. So I have to say that as the field is moving forward, we're going to be using more implantable loop recorders than we have in the past, based on the perception, again, that they are more efficient in detecting AFib, and they definitely will be mandatory in patients that either have risk factors or their age is above 65 or so. Now, what happens, we're going to switch gears now and talk about what happens after you do a PFO closure and the patient develops AFib, which we all have seen happen. It's a real issue. I think that it happens, and we're going to talk about what exactly is the data out there that describes this phenomenon. So we know in all randomized trials that AFib post-closure is increased compared to standard medical care, regardless of the device. So if you look at the randomized studies that have been done today, you can see that in terms of what is the incidence of atrial fibrillation, it's about 6% on the reduced clinical trial versus 4% in the RESPECT. But if you look farther down on the slide, you're going to see that the incidence of serious AFib, which was described either as a prolonged episode that lasted more than a day or had an impact on the patient's life that required admission, it was only approximately about 2% on reduced and 1% on a RESPECT clinical trial. Now, in terms of the severity and time course, the reduced study found the following. So it turns out that most of these episodes of flutter or AFib were considered to be non-serious. So it's either temporary, transient, that many times the patients, just had a brief episode of palpitation that goes away. This is, at least 66% of patients met this definition. The other interesting thing is that when it happens, it tends to happen early after the procedure, within the first 6 weeks, and up to 83% of the patients. And even more important is that it's usually gone 2 weeks after the onset in about 60% of patients. So we get a pushback from referral cardiologists or neurologists when they see a patient that has an episode of AFib after closure, and the first thing the neurologist will come and tell me is, I told you so, this patient was not a cryptogenic stroke. I mean, he had AFib as the cause of the stroke. So then you have to pedal back and you have to educate the community and say, listen, AFib has been observed after PFO closure. Here's the data. It's rare. It happens in about 4% of the patients. It's serious on only 2%. I'm expecting that this is going to be temporary. It's going to go away, and it's going to be gone by 6 months. So this doesn't mean that the patient is then committed to lifetime anticoagulation with one single episode detected after the closure. And then the last slide of my talk will talk a little bit about how I see this issue in the clinical practice. So the clinical consequences of AFib post-closure, and so if you have one episode of AFib, does that impact your risk for recurrent stroke? And it turns out that it doesn't. So if you look at both trials, in each one of them, only one episode of recurrent AFib after closure was implicated as the cause of a recurrent stroke. So we have a rare issue that doesn't have a clinical impact enough to change the common sense that will dictate that this is not, you're not committing someone to lifetime AFib doing a PFO closure, as some of the physicians out there are believing nowadays. So the key points here, so we know that AFib is more common after the implant. Typically, it happens within 45 days. Serious AFib is really rare. The risk for a stroke in an AFib is low. And there is an increased incidence of AFib after closure. The clinical trials still show that there was a significant reduction in the risk of recurrent stroke at 2 years. So that is the most powerful piece of data. It's okay to get a little bit of AFib. It's not going to cause a stroke, and you're still providing the patients with their benefit of reduction in secondary strokes. So in one side, we have the stroke reduction and the risk of AFib, and Megan was already alluding to this very intriguing app that I just actually prepared on this talk I got to use, and it's prepared by the British Medical Society, which their publication is the British Medical Journal, so they get together, including patients' opinions about how they feel in the treatment of certain conditions, so stroke and PFO risk, AFib, and so forth. And Megan already alluded that in the opinion of the British Medical Society, the PFO closure reduces the risk of stroke and outweighs the undesirable consequences, including atrial fibrillation. So finally, I'm going to talk a little bit about what do we do if you have a patient that has a closure and presents with an episode of AFib. So what I do, the first thing I do is I start anticoagulation. You can argue, well, why are you going to do anticoagulation if you're telling me that you're expecting this to be short-lived and so forth? And I actually do it just because I think that if you leave a patient without anticoagulation and they happen to have a TIA or a stroke in that setting, I think you're going to be, in a bad situation, both from, as a physician and as a, referral doctors will get upset, particularly. But it also could be, a liability of mistreatment of a patient that, has AFib detected after any procedure. So I started them in anticoagulation. I usually use a NOAC in the young patients. And then I implant the monitor. I think anyone that has an AFib episode, you really, really need to get a handle on what is going to be the time course of AFib, how many episodes are they going to have moving forward. And I leave the monitor. I actually monitor throughout the patient's, the battery duration, which is nowadays approximately 3 years, because even if you prove that the AFib, is gone, it's very important that these patients continue to be monitored because, their risk could be potentially higher across the board to have subsequent AFib down the road that perhaps could be even unrelated to the device itself. And I only will consider discontinuation of the anticoagulation if I have no recurrent events, which in my mind have to be more than an hour, for at least 1 year of consecutive recording before you can say to a patient, listen, I think your AFib was short-lived after the device. It's okay to come off the anticoagulation. And obviously, when you do that, continue to monitor the patient because, you're at that point, that device is there on the battery. I thank you for your attention, and I'm open to questions that include all the prior talks.
Thank you, Ignacio. So we have about 5 to 8 minutes for questions, so let's make use. Yeah.
Great. Thank you very much. Excellent talk. Excellent talks. Question about your very last slide. I'm not sure if you'll be able to go back to it, but I can reiterate quickly. Post PFO closure AFib, start anticoagulation, implantable loop recorder. Where'd you get the number 1 year?
Yeah.
I only ask because
I know.
my is very similar, but
Right.
the number I made up is 90 days, and I'm curious
Yeah,
what you think, what other people think, what
Right.
people are doing.
I mean, I think it's all made up, of course. I think I just really will feel that if you don't have it for a year, I think you're definitely out of the woods. You could, if you have an implantable recorder, I guess you can do it at 90 days and just monitor the patient. At the sign of any recurrence AFib, you can restart the anticoagulation. But yeah, I mean, I think hopefully there will be clinical trials that will be done addressing this issue. And the only way we're going to know for sure is do an implantable recorder population of patients that undergo closure and follow this prospectively.
A great advantage of the implantable recorders is that patients can do home monitoring. That's been our bias in the 90-day,
Right.
again, made-up numbers. We do 90 days, there's no
Right.
AFib, we stop anticoagulation, but they still have a loop recorder and they're monitoring themselves and transmitting
Correct.
from home.
Correct. Yeah, I mean, I think we usually get referred patients that haven't had a loop recorder implanted and there's some pressure into doing the PFO closure soon because they might need a surgery or there have been a handful of patients in which we've done both procedures at the same time. So we do the closure and then the EP guys come in and implant the loop, particularly in older populations. So.
Any other questions? Yeah, I think we need to keep in mind that PFO closure can only prevent PFO-mediated strokes. So the fact that we continue to see a few events after closure is really failure of recognition of other potential mechanisms. And I think that brings, to your point, Ignacio, maybe the need for implantable loops regardless of a PFO closure or not. I mean, there's a subset of patients that perhaps do develop AFib, perhaps completely unrelated to PFO, the PFO device itself. So I believe that some of these strokes that we see in the closure arm are related to a PFO-mediated stroke. And I think that's important to acknowledge.
If you look at the Closure 1 study, there were 6 patients that had a stroke after the device was implanted that at presentation had an AFib. And coincidentally, all of those 6 patients had full closure of their PFO, which was a rare thing in the CardioSeal device. So that proves you that perhaps some of this recurrent stroke could be undetected AFib, and then doing routine monitor will hopefully answer that question.
I guess that concludes the session. Thank you for being here today.